I'm gonna talk about procedures that we do all the time, but they sound very complicated, like nephrostomy tubes, double J ureteral stents, nephroureteral stents, ureteroscopy, and lithotripsy, and they sound very complicated, but I will explain everything to you. The urinary system is composed by two kidneys, and then the collecting system, which includes the renal pelvis, which is this large sac that collects the urine from the kidneys, then the ureter, which is this long tube that brings the urine all the way down to the bladder. Then you have the bladder, which is the sac that collects the urine in the pelvis, and the ureteral, which is the tube where we pee from. And obviously the kidneys are super important to filter your blood and get rid of toxins. And for them to work, you need this whole plumbing system to be working fine. Blockages can happen anywhere, but there are two places that they happen more often. One is called the UPJ, ureteral pelvic junction. That's the junction between the renal pelvis and the ureter. And sometimes people can have a congenital blockage here, but a stone also tends to get stuck here because that's where you have a sudden change in caliper. The other place is where the ureter meets the bladder, called the UVJ, or ureteral vesical junction. And the ureter tends to get more narrow in this area, so stones tend to get stuck here very often. Also, that's where bladder cancers, for example, would block the ureter because they grow into there and will block it. And also the prostate, when it grows, it can also block this area as well. There are several reasons to have a blockage in the urinary system, and I mentioned some of them already, that include kidney stones and cancer. Now, the cancer could be either cancer that starts inside the collecting system, inside the ureter or the pelvis, which is called a urothelial cancer, also known as transitional cell carcinoma. Or it could be a cancer that starts somewhere outside, for example, in a lymph node or in a pelvic mass, and then it starts pushing on the ureter or any part of the collecting system. There are also other benign diseases that can cause strictures, including something called retroperitoneal fibrosis, which will narrow the mid-ureter, scar tissues from prior surgery, for example, or infections. In some surgeries, for example, you can have a damage of the ureter because it's difficult to see. For example, a hysterectomy or a colon resection are some of the surgeries that can be associated with this. Now that we know the anatomy and we know the causes of blockages, let's talk about some of the procedures interventional radiologists use to relieve this blockage. So when you have a blockage in the urinary system, there are two ways that you can go by relieving this blockage. One way is usually done by urologists, and that's when you go through the urethra into the bladder, and then you find where the ureters are connecting to the bladder, and you get a little wire into the ureters, and you can relieve the blockage that way by putting a double J stent, for example, which is a long tube that extends from the kidney to the bladder. Obviously, a blockage in the urethra, all you need is a Foley catheter or a urinary catheter that will take care of that. And usually it's preferred because going through the urethra is more natural because you don't have to go through the skin and all stays inside. But sometimes the urologist may not be able to do this, either because the anatomy is a little tortuous or because there's a blockage at the opening of the ureter into the bladder, or because the patient is very sick and they can't undergo general anesthesia, for example. And that's why interventional radiologists are often key in your treatment. Interventional radiology procedures are often done under imaging guidance by inserting a catheter or a small tube directly into the kidney through the flank. And as you probably know by now, interventional radiologists specialize in doing image-guided procedures and navigating catheters through your entire body. We're essentially human plumbers. Now, the simplest procedure we can do, it's called a nephrostomy tube. A nephrostomy tube is when we insert a tube guided by imaging, including ultrasound and x-rays, directly into the kidney through one of the calyces, which are these small entrances in the kidney, and put the tube directly into renal pelvis. The nephrostomy tube will then be coming outside of the skin into the flank and will be connected to a drainage bag and will drain the urine to a drainage bag. Now, obviously, if one kidney only is blocked, we'll put a nephrostomy tube only on one side. But if both kidneys are blocked, you would need two nephrostomy tubes and two different bags. A nephrostomy tube placement is usually a quick procedure. can be done with just local anesthetic, but most of the time we use a little bit of sedation so you're more comfortable. They probably on average take about 10 minutes. And usually it's the best procedure for somebody that is very sick. Let's say you have a urinary infection related to a blockage, related to a stone. In those situations, you have a lot of bacteria, probably pus in the urinary system. So if you try to do too much and manipulate and try to push too many catheters through there, patients can get very sick. They can get septic because some of that bacteria may go into the bloodstream. So in those situations, we try to keep it simple. And the first thing we do is to put this nephrostomy tube, we relieve the blockage, and then once patients are better, we can think about some better solutions. Or even just putting the nephrostomy tube, patients can get a little sicker temporarily, but then they tend to get better after a few hours. And of course, we'll continue to improve now that the system is drained. Now, the second procedure that we do is called that double J ureteral stent. What a double J ureteral stent is basically a long tube that measures about 2 to 3 millimeters and extends from the renal pelvis all the way to the bladder. It has holes in both sides, so the urine can go through the proximal holes, go through the tube, and then go to the urinary bladder, bypassing any blockages. Now, this can be done in patients that already have a nephrostomy tube, or it can be done as a first procedure if that's the best option for the patient. The way interventional radiologists do is usually they go through the back, through the flank, and they can pass a little catheter or a guide wire all the way to the bladder, and then they insert this tube over the wire as a railroad. And this is usually done under X-ray guidance. We can see the catheters going through and forming in the right place. Sometimes if the blockage is very tight, we may dilate that blockage with a little balloon before we put the stent to make it easier. But most of the time we're able to accomplish this. Of course, in some situations, for example, if somebody cut the ureter or the blockage is extremely severe, we may not be able to go through, and maybe the ureteral stent may not be an option, but this is very rare. And then once we have the ureteral stent in, we may either remove the nephrostomy tube or we may just cap the nephrostomy tube to make sure the ureteral stent or the double J stent is gonna actually work. And the way we know it's working is we can repeat an ultrasound a few days after to see if the system in the kidney remains dilated or if decompressed, which means that it's draining well. Of course, if the process is bilateral, then if you have bilateral blockages, your renal function will go down and a blood test called creatinine will go up, and we can use that to monitor if the stents are working as well. Now, these are the most common interventional radiology procedures that we do, but one problem with them is any tube you put in the collecting system in the kidneys needs to be changed every 3 to 6 months. And I'm going to explain why is that. One of the important functions of the kidneys is to excrete calcium, and we all have calcium in the urine. Some patients more than others. And with time, if you leave any foreign object within the urinary system, you create calcium buildup in these tubes. And if you leave these tubes more than 3 to 6 months, we'll create so much calcium buildup that will block these tubes. So if you have any tube in the urinary system, either a Foley catheter, a double J ureteral stent, or a nephrostomy tube, they will need to be changed usually every 3 to 6 months, but every patient is different. Some patients may build up more calcium than others. And I have patients that have to be changed every 6 weeks because they are so much builders of calcium that it ends up being necessary, but on average, 3 to 6 months is okay. Now, the way nephrostomy tubes are changed, it's a very easy procedure, sometimes done just with local anesthetic, and it's literally a 2-minute procedure. And what we do is we put a wire through the nephrostomy tube, which is a railroad track, like I mentioned before. Then we remove the nephrostomy tube over the wire under X-rays, and we place a new nephrostomy tube. Now, can't be done in the office, it needs to be done under X-ray guidance. Now, ureteral stents, because they are all internal, they need to be changed through the bladder. So the way we do this is we insert a little catheter either through the penis or through the female urethra into the urinary bladder, and then we use a little endovascular snare, which is basically a little snare to grab that tube, and we pull this tube out a little bit, and then we place a wire through the tube and exchange to a new stent over the wire. Now, there's an option in between that's called a nephroureteral stent. And we don't use this as often, but sometimes it may be a good idea. A nephroureteral stent is a longer tube that is a mix between a nephrostomy tube and a ureteral stent. What it does is a tube that is coming from the outside, and then it goes into the kidney, it makes a loop into the collecting system, into the renal pelvis, and then goes all the way to the bladder. And the nephroureteral stents, like I said, they are hybrid between nephrostomy tube and a nephroureteral stent. And they can either be connected to a bag, or the catheter can be capped, can be closed with a little cap, and then they work like a ureteral stent. Now, this is advantageous because they are easier to change than a ureteral stent because they can be changed the same way as a nephrostomy tube is changed, which, like I mentioned, is a quick procedure with local anesthetic, sometimes no need for sedation. And we just insert a wire through the tube, remove the tube over the wire, and put a new tube. So for patients that have bladder problems or difficult obstructions, they may be a good idea. Now, I also mentioned I was going to talk about what's called ureteroscopy and lithotripsy. Those are also procedures we can do, and that's where we insert a little camera through these tubes to navigate inside your urinary system so we can see if the blockage is due to a stone or a cancer or what it is, what's going on. When we do a ureteroscopy, we can either, if we see something that looks like a tumor, we can do a biopsy guided by direct visualization. Or if we see a stone, sometimes we can use a little fiber, a little wire that can emit laser or shock waves to kind of try to break that stone and get it to come out. We can also place a little basket that we can use to pull the stone out. And the ureteroscopy can be done either by inserting this camera through the skin in the flank, like the same way through the nephrostomy tubes, or they can be inserted through the urethra into the bladder and then into the ureter. They can be done both ways. Now that you understand what's the difference between these procedures and tubes, I'm going to talk to you about what to expect after the procedure and how do you manage going forward. So the simplest to talk about is the ureteral stent because there's nothing outside, it's located only inside. So there's nothing really that you need to do. But I'm going to tell you some things that you can expect after the procedure and how to handle them. So one of them is that any of these procedures can cause blood in the urine for a few days. And also important to know that if you have any tubes or stents or anything inside the urinary system, you can have intermittent blood in the urine, which is caused by irritation caused by the tube into the urinary system, basically. The important thing to know is usually it's less blood than you think. So if you look at the urine and you can see through the urine, it's not completely opaque, that's usually a very small amount of blood. So that you shouldn't worry about. Now, if you start having blood clots or very thick blood, then you probably should contact us and we'll take a look and see what we need to do. Most of the time we'll just watch it. Sometimes we may need to flush it and do something like this. Now, the main problem is if you have a lot of blood, you can create blood clots and can block the outflow of the urinary system, block the urethra so you can't pee. If that happens, you need to come to the ER. We'll probably need to put a catheter, and sometimes we irrigate that catheter with saline until the bleeding stops and you can urinate normally. Now, to get to that point is a very rare thing with any of these procedures. Now, going back to the ureteral stents, so most of the time there's nothing you need to do. Some patients have some irritation of the bladder, so they may feel like they have to pee very often in the beginning. They may also have some pain when they pee. Most of the time it resolves. We can use some medications like pyridium or Uribel to help with this, but most of the time they are self-resolved. Obviously, if they continue to be an ongoing problem, we need to do something about it. And some patients may not tolerate a stent at all, but this is not common. Now, like I said before, the stents will need to be changed every 3 to 6 months and will depend on each person and we'll make a plan accordingly. You know, usually sometimes we start by changing every 3 months, and if they look in good condition with no calcium buildup, then we'll start extending to 6 months or so. Now, when you change the ureteral stents, it's usually done through the urethra and can be done by the interventional radiologist or the urologist. We'll make a plan accordingly for you. We usually work very closely with the urologists as well as a team. Now, nephrostomy tubes and nephroureteral stents are a little different. And obviously, if the nephroureteral stent is capped, and that was the recommendation, then there's nothing you need to do. Both these tubes are going through the skin in the flank. They usually have a little stitch that are holding them in place so you can't remove it. Now, it is common for the skin to be a little bit irritated around the tube. That's usually related to the stitch. The best way to handle that is to secure the tube maybe with a little piece of tape or a bandage to prevent it from moving, and that will decrease the irritation. Over time, it tends to get more healed around the tube. And the way I like to say is these tubes become like an earring that people are used to. So your body basically heals the skin around the tube. So it eventually becomes part of your own body, right? Some patients may live the rest of their life with nephrostomy tubes if they don't have any other option, although not ideal, but that's a good option, better than losing your kidneys and going on dialysis. So when they go immediately in like a earring, they can get a little bit inflamed, so the site can be a little bit red, a little bit painful, but that should improve over time, over 1 to 2 weeks. It's also common to have a little bit of inflammation where the stitch goes in the skin, and it tends to be more inflamed if you keep tugging on the tube. Now we're going to talk about how to take care of your nephrostomy tube and nephroureteral stent. And we're going to talk first how to take care of the site. Now the key of taking care of the site is to keep it clean and dry. Now, can you shower when you have a nephrostomy tube? Absolutely. We usually don't recommend like getting wet right away, but after a week you can certainly shower. Can you shower with a earring? Of course, because it's already healed around it. It's not a problem. Like, it's not that water will get in and go into the kidney. You can shower. And I actually prefer you to shower because the key is to keep the site clean and dry, like I said. So as long as after the shower, you dry it very well and then change the bandage over it. Now, you may see some nurses and some people try to make very elaborate dressings around these tubes. I don't think that's necessary. My best recommendation is to use a 4 or 5-inch pad that you can just put over the dressing. I'd rather keep it simple so you can change the dressing every day. You can change that pad. It is a very easy thing to do and keep things clean and dry. Now, the tubes tend to be very flexible, so they don't usually bother people. They can even lay on the tubes. It's fine as long as they don't get kinked. And if they get kinked for a little bit, it's also okay, as long as every once in a while you open the tube. Now, nephrostomy tubes are always connected to a drainage bag, so the urine will come out through the drainage bag. Nephroureteral stents, or NU stents, those can be either closed with a little cap or they can be connected to a bag. They are a hybrid system like we talked before. So the site may have some irritation, but a little bit red and painful at the site, but should get better over a period of 1 to 2 weeks. Now, if you have the tube for a long time, you'll get inflamed every once in a while and then get better. Usually we don't require to put any creams or bacitracin over it. Just keeping it clean and dry is enough. But in some situations, if it's getting red, I don't think it hurts to put some bacitracin on the top as well. Now, if the redness starts to spread around the tube, so like for more than ½ an inch or so, that could mean you're developing an infection around the skin called a cellulitis. In those cases, you need to give us a call since you may need antibiotics. There can also be a little bit of drainage or fluid around the tube, should be only a small amount. So if it's leaking a lot, like everything getting wet and soaked, you need to give us a call. We need to troubleshoot. That may be because the tube was partially dislodged, or may have a problem, or the tube is completely blocked. So that may indicate a problem. But a little bit of drainage, like a few drops, wetting the bandage, just make sure the bandage stay dry, change it. But there's nothing that needs to be done. Once the tube is placed, you can also have a little bit of blood around the tube for a few days. If it's just a little bit, few drops, don't worry about it. If there's a lot of blood, then obviously you need to give us a call. And again, keep in mind to change the pad as frequently as possible to keep it dry. So that's all we need to know about the site. Now let's talk about the tubing and what is coming out the tube. If you're draining to a bag, you should always have a constant drainage of urine through these nephrostomy tubes. So if you don't have drainage for more than an hour or two, the first thing you need to do is make sure there's no kinks or anything like that. The second thing you can do, if we trained you to do that, is to flush the tube, make sure the tube is open. If that doesn't fix the problem, you need to contact us. Now, this is not something that you need to contact us in the middle of the night. You can wait until the next morning and call the office first thing in the morning. And then we'll probably need to see you that day and troubleshoot this and find out what the problem is. It could be that the tube was dislodged or the tube is clogged, but there's probably some problem there. Like I mentioned before, whenever you have a tube in the urinary system, you can have a little bit of blood intermittently. When you look in the tube and you can see through the blood, if it's a little bit translucent, it's not a problem. It's usually just a small amount of blood. But if you're getting like thick blood and heavy clots, you also need to give us a call. If it's a huge amount, you should go to the emergency room and give us a call. But again, that's very rare. Usually because you have a constant stream of urine, these tubes do not need to be flushed, but in situations that they get blocked, if you know how to do it, you should try to flush, see if you can unblock it. That's one way to troubleshoot it. As far as the external bag, my recommendation would be to change that bag at least once a week. There you can change at home. It's very easy. It's usually just what's called a lure lock. You just screw in and screw out. Same thing as a screw, so righty-tighty, lefty-loosey, and that's how you do it. You can buy these bags on Amazon or any medical supply store. They're very easy to find. You can search nephrostomy drainage bags on Google or Amazon and you'll find them. We can also provide a link in our website. They're not very expensive. Again, like any tubes that go in the urinary system, they need to be changed periodically. We usually change nephrostomy tubes every 3 to 6 months, but depending on the patient, it may need to be sooner, but we never go more than 6 months or so. Now, we're gonna talk about some warning signs for any of these procedures. Essentially, you can have some pain at the procedure site. That can be normal, of course, but if you develop severe pain, like that is excruciating, that you're requiring narcotics, you need to contact us. It could mean that you have internal bleeding, which is one of the main complications of this procedure. Another complication of this procedure is sepsis, like I mentioned before, especially if you have any stagnant urine in the urinary system, it tends to grow bacteria, like the same way that if you have any stagnant water anywhere. Now, when we put these tubes in and we decompress, we can have an initial worsening of the sepsis because some bacteria may go in the bloodstream for the procedure, so that's almost expected, but usually patients tend to improve very quickly over the next few hours. For that reason, most of the time we give antibiotics before we do any of these procedures. Indeed, if you come for a change, and if you already had these tubes for a while and you come for a change either of a stent or a nephrostomy tube or an ANU stent, sometimes we may recommend you to take antibiotics at home for 2 days before the procedure and 2 days after the procedure. And sometimes we may just give you a dose of a powerful IV antibiotic at the time of the procedure. It will depend on case by case, but you should ask us about it. In the same token, if you have a repeat blockage of the urinary system, you may develop a fever or an infection. They can be quite serious. People can get septic. So if you develop a fever, you need to go to the emergency room and give us a call. Another issue that may come up is if you stop making urine. If you have a stent, it would be like regular urine, but if you have a nephrostomy tube, is if you stop putting urine out in the nephrostomy tube, it can also be an emergency and you need to give us a call and potentially go to the emergency room if you can't urinate. And those would be the main things on taking care of your nephrostomy tube. Again, if you start seeing any of the warning signs, don't wait too long. Call us, go to the ER, do whatever needs to be done, because it's easier to tackle these problems earlier before you get a bad infection or something else happens. I hope this video was helpful to you. If you have any other questions, don't hesitate to contact our office.